Good evening, friends. We have it's 8 o'clock. We warmly welcome all the faculty here. Professor Nishikant Pujar sir from Alamin Medical College, Dr. Rajiv Sakai sir, and other senior faculty here who are expected to join shortly. We have two candidates. One is kindly contributed by Dr. Professor Amit Gupta, All-Day Institute Rishikesh. She's Dr. Palak. And the other candidate is Dr. Somaya. She's from Alamin Medical College, kindly contributed by Professor Nishikant Pujar sir. And today we have vascular cases discussion. We have one venous case and one arterial disease case for this evening. So the first case will be arterial disease case from All India Institute of Medical Sciences, Rishikesh. Dr. Palak, please introduce your unit chief, head of the department, and then start your presentation. Faculty, kindly take over. Thank you very much. Can you share the PPT, ma?
Yes.
Yeah. Good luck to you. All the best.
Good evening to all the respected faculties. My name is Dr. Palak. I'm a second year postgraduate resident from AIMS Rishikesh. My moderator is Dr. Amit Gupta, Professor, Department of General Surgery, and my HOD is Professor Somprakash Basu, sir. Today I'm going to present a case on peripheral vascular disease, beginning with the history. A 54-year-old gentleman, farmer by occupation, resident of Saharanpur, UP, presented in general surgery OPD with chief complaint of on and off pain in the left lower limb for the past 1 year and blackish discoloration of the left great toe for the past 20 days. History of presenting illness. Patient was apparently well 1 year ago when he developed pain in his left leg in the calf region, which was insidious in onset, cramping in nature. It was brought on by walking, and patient had to stop for at least 5 to 10 minutes to take rest to be able to walk again. However, on taking that period of rest, he was able to walk a comparable distance. The pain was relieved on taking rest. Initially, the patient was able to walk around 1 kilometers without any difficulty. Gradually, this distance has decreased such that for the past 2 months, the patient has pain on walking up to the bathroom around 100 meters. And for the past 1 month, patient has continuous pain in the leg affecting his sleep. This pain is partially relieved on the sitting position and hanging legs by the side of the bed. 20 days back, the patient noticed blackish discoloration of the tip of his left great toe, which gradually progressed to involve the entire toe with loss of sensation and only mild inability to move the great toe. There is no history of trauma, fever, overlying skin redness, or swelling on the leg or along the course of the veins, pain or bluish discoloration on exposure to cold, joint pain, lower back pain, pain on standing upright for long duration, pain in the thigh or the gluteal region, postprandial pain, chest pain, syncope, blackouts, or any loss of consciousness or loss of vision. Past history, the patient is not a known case of diabetes, hypertension, CAD, or pulmonary TB. There is no history of any past surgical intervention. Personal history, smoker. The patient has been smoking BD for more than 20 years, 1 bundle per day. Pack years are 20 pack years with occasional consumption of alcohol. There is no history of any concurrent tobacco chewing. Patient consumes a mixed diet. Appetite is normal. His sleep has been disturbed recently due to pain, and other bladder and bowel habits are normal. Family history, there is no history of any diabetes or coronary artery disease in the family members. To summarize my case, a 54-year-old gentleman, chronic smoker, presented with pain, intermittent claudication in the left calf for the past 1 year, gradually progressing to rest pain for the past 1 month, associated with gangrenous changes on the left great toe since 20 days with no other comorbidities.
Go to previous slide.
Okay, Dr. Palak. Go to your first slide.
Previous. Why you
Okay,
ask
Dr.
history about?
Palak, you said that. Okay, sir, please.
Okay, sir,
Sir,
continue.
No, sir, please, you start off, sir.
Why you ask history of pain in abdomen?
sir, can you please
In this
repeat? It's not clearly audible to me.
in negative history, you have mentioned that there is no history of pain in abdomen. है ना? In negative
Pain in
history.
the
Postprandial
abdomen.
pain. Why you ask
Post-
history of postprandial pain? What is significance
Sir, I
related to
wanted
this
to,
case?
yes, sir, I wanted to rule out the mesenteric ischemia, sir. I wanted to rule out mesenteric ischemia, whether the patient is having pain on any consumption of foods after consuming foods.
Any significance to this case?
Yes, sir, because
Whether
I
it is
want to rule out
related?
whether the patient is having concomitant disease in any other arterial segment or not.
Okay, then why you ask history of pain in the thigh and gluteal region?
So for the same reason, to look out for any proximal extent of the disease, whether it is involving any other proximal arterial segment.
So what? Suppose there is a pain in a gluteal region. Where is
So
the
then
obstruction?
so if the patient is complaining of any pain in the gluteal region, I would think of disease involving the proximal segment, like aorto-iliac this segment of the vascular tree.
What is terminology for that?
So Lerich syndrome.
What are the components of this syndrome?
So
How the
Lerich
patient will.
syndrome will present as pain in the thigh or the gluteal region with the sexual impotence and absent of distal femoral pulses and distal pulses as well.
Okay. Sir, you please continue.
Okay, okay, Dr. Palak, you've taken the
Yes, sir.
history. What do you think you're dealing with by history?
Sir, based on my history, I'm thinking of a diagnosis of probably peripheral arterial occlusive disease, which is most likely due to atherosclerosis, sir.
Where?
What do you mean
Where
by
exactly?
peripheral arteries? What do you mean by
Where
peripheral
exactly?
arteries?
Okay,
What do you mean by peripheral arteries?
So the peripheral arteries are the muscular arteries, which in the upper limb can be brachial, axillary, subclavian, radial, ulnar, and in the lower limb they can be femoral, popliteal,
But
and the
look,
tibials along with.
Palak.
You thought about
All arteries which are branching from the aorta, all arteries branching from the aorta are peripheral arteries. Why are you saying just muscular?
see, remember,
Yes.
aorta is also a peripheral artery. Arteries other than coronary
All
artery,
from the heart.
brain artery, this artery supplying the brain and the heart, all are peripheral arteries. So it is not that just a femoral arteries alone, it is there. Okay. And why you are very particularly asking for the postprandial pain? Why not it is just an abdominal pain?
Why not?
Abdominal pain. Why do you want to specifically say there is no postprandial pain?
So, like patients with in mesenteric ischemia, they will complain of pain when they after they consume food. So for that reason.
So what is that mechanism? Why do they get the pain after the food only?
So it is because the normally the blood supply will be directed to the gut. It will be adequate for the digestive system to operate. But in cases with mesenteric ischemia, the supply and demand is relatively mismatched, and for that reason, the patient will complain of postprandial pain.
What is the cause you think that is a postprandial pain? Is it the ischemia? It is thrombus? It is a embolus?
Sir, in mesenteric ischemia, sir. Sir,
No,
ischemia.
ischemia due to what?
Sir, thrombus. Embolus will be a more acute phenomenon.
both can produce thrombus and emboli. And what is the difference between thrombus producing ischemia and emboli producing ischemia?
Sir, in embolus producing ischemia, the presentation will be more sudden and stark. There will be sudden pain, and the patient since there will be no formation of any collaterals, there will be no time in the acute process leading to any formation of collaterals. Therefore, it will be a totally uncompensated disease as opposed to thrombus forming ischemia, in which case the collaterals will be well developed and it may be a compensated disease to begin with.
So you prefer to have a thrombus than an embolus?
So, sir, can you please repeat, sir?
You prefer to have a ischemia due to thrombus than it is due to emboli. Is it true? Emboli usually goes to the peripheral vessels. No? The area of damage it is going to cause will be less. But if it is a thrombus is causing that ischemia, it will be on the junctions. This is superior mesenteric artery origin. So the damage you are going to get is also going to be very high. Okay. But other explanation is also acceptable. What you said, it's a collateral formation is acceptable. And one more question, and you talked about impotence. Why do you get impotence
Yes.
in Lerick syndrome?
So you are asking the cause for that?
Yeah. Why do you get?
Sir, can you please repeat? I am not able to hear the question.
That Lerick syndrome components are as asked the question. You said impotence is a component of a Lerick syndrome.
Yes, sir.
It is a part of a Lerick syndrome. The patient will get the impotence. And how do you get the impotence? Why do you get impotence? What is the
Sir,
mechanism of getting impotence?
So, impotence will be due to inadequate blood supply to the penis because of internal iliac artery is not getting enough blood supply because the proximal segment is only blocked
What is the blood supply to the penis?
from the internal iliac artery, sir.
That we know. So it is no name, no?
Sir, dorsal artery of the penis, sir.
Very good, very good. Then, okay.
Okay, Dr. Polak, good history, right? Okay. You said this is a peripheral vascular disease, probably due to atherosclerosis, right?
Yes, sir.
Okay. Where do you think is the obstruction here?
Sir, what do I think is the distal?
Where do you think is the site of obstruction in the artery?
Sir, it may be femoropopliteal, sir, in this case, because we're looking at a disease which is patient is complaining of pain in the calf region. So it may be femoropopliteal to begin with, sir.
Okay. So if there's a pain in calf, which is the commonest site for atheroma formation?
Superficial femoral artery, sir.
Where? Okay. Do you think are atheromas common and why? Anywhere in the body, where do you think atheromas are common and why?
Sir, atheromas will be common at the site of branching or where the vessels are.
Yes.
There's a change in a
Right. Very good.
caliber
Where there are
of the
branches,
vessel.
where there's branching because of
Change in the
of
caliber of the vessel, sir.
turbulent flow there, right? There is turbulent flow there. So
Yes.
in the thigh, where do you think is the commonest site now? Let's come to that.
Sir, in the thigh, it would be proximally at where the branching takes from both the common femorals, they'll branch into external and iliac, internal
So if it is at
iliacs.
a common femoral and that's the commonest site, then you should get pain in the thigh. Why do you get pain in the calf? Which is very common. Because the commonest site is where the femorals emerge from the adductor canal. That's the site, right? At the
Yes.
adductor canal. Right. Okay, let's go back to your first slide. You said that the patient has been having pain in the calf and then relieved by taking rest. Next slide, please. So, do you think the patient, is he improving or is he getting worse?
So he's getting worse.
Why do you think he's getting worse?
So because now he's complaining, first of all, the distance which he's able to walk is also decreasing. And second of all, the pain, now he has developed continuous pain in the leg, which means even at rest, the metabolic demand is not able to be met by the blood supply. So,
Is it true? Breast pain is due to the metabolic demand? What do you mean by rest pain?
so rest pain is due to no, when even at rest, there is a mismatch between the supply and the demand, and also the nerves are not getting any supply. It's
See,
the
the claudication pain
neural.
is entirely, claudication pain is different and breast pain is different. It is not a continuation of the claudication pain. Breast pain is entirely due to the nerve pain. And why do you get a breast pain? Why do you
Sir,
get
because
breast
of neural, yes, sir, because of nerves are also not getting blood supply.
pain? Which nerve will be affected first?
Sir,
Why do you
the
get
sensory nerves.
No, what is the common site of claudication pain? What is the common site of rest pain?
So common site of claudication will be the calf, sir, and common site of rest pain again, distal calf and foot region.
No, it is not cough. You will never get a cough, rest pain in the cough. The rest pain is only in the foot, the first to start with always. It supplies the farthest nerve. The nerve which is far from the heart is the first nerve to get affected. And it is only an affecting of a nerve which is going to have a rest pain. Claudication, distance, claudication cannot. What is the definition of claudication pain? What is the criteria of claudication pain?
Sir, it should be reproducible, sir. It's a reproducible muscular pain, which is like cramping in nature.
Okay.
And it is brought on. It is brought on by walking, and then it has to be. It should be relieved
Yes,
by when the patient
absolutely.
takes adequate
So,
rest.
the first criteria is no pain at rest. If the patient has a pain at rest, it is not claudication pain. So no pain at rest, then on exercise you get a pain, and that pain is going to be relieved. That is what is the mechanism we are talking. So claudication pain is entirely different. Pain, concept, function, and which muscle is affected is different. Rest pain is different. What is the significance of rest pain? Suppose he says there is a rest pain, and you say that it is a rest pain. What is the significance?
In when we are talking about rest pain,
Yes.
so rest pain will signify that the disease is progressed to a level of limb-threatening ischemia, and the
Yes. That is what we are.
patient.
No, hang on.
What is
What
meaning
you,
of rest?
you think rest pain means that there's critical limb ischemia?
No, sir, it does not mean it is one. It may signify limb-threatening ischemia in a patient.
Okay.
Rest pain not
And
responding treatment for more than 2 weeks is a criteria to call it as a critical limb ischemia.
Okay. Palak.
yes,
Now, what was the position of the patient when he was sitting on the bed? Was he holding his foot in his in his hands?
When he was sitting on the bed.
Sitting on the bed, yes. You find so many times these people with the rest pain, they hold their foot, the cup with hands. Okay, why do they do that?
S-
Because
sir, I'm not
to
aware of
keep
this.
the foot warm. The hands are warm, right? So they hold it with the hands to keep it warm so that that warmth will increase the blood supply and they get some
Right.
relief. That's why most of these
Yes.
patients who have chronic rest pain, you find them having contractures, flexion contracture at the knee joint because they keep
Yes.
sitting that way. Okay. Next
Yes.
slide, please. No, just the blackest discoloration. Left great toe. Okay. So which artery is involved, do you think, if the great toe is getting involved?
Sir, the digital branch from the dorsalis pedis to the left first great toe.
Just that much?
Sir,
Okay, okay. So, do you know the angiosome of the foot?
angiosomes.
You know what is an angiosome?
Yes, sir. It is a unit which is supplied by is basically a concept we use in deriving like from one main vessel there are pedicles which will supply the skin and the subcutaneous
And
and
the tissue. Okay, which is the main artery of the lower of the leg?
main artery of the leg, sir. From popliteal, and then it will divide into anterior tibial, posterior tibial, and peroneal.
So, of the three, which is most important?
Sir, anterior tibial.
No, it's the posterior tibial, right? Okay. So here, which vessel is being involved now? Now you tell me.
Mhm.
So
Sir,
dorsalis
the
pedis is a branch of
anterior tibial.
right. So it is anterior tibial, right? Which is being
Yes,
involved
sir.
here. So the anterior tibial, the medial and the lateral peroneal arteries.
Yes, sir.
So there are three arteries through the great toe, right? Okay. Next, go to your next slide. Okay, what are the risk factors for developing atherosclerosis?
Sir, risk factors.
Major factors and minor factors. Which are the major factors? Which are the minor factors?
Sir, major factors will be age, sir, diabetes mellitus, and hyperlipidemia.
Give me the most
Hy
important first. Palak, you can't give me the least important ones. You're reading from below, so you start from top. Which is the most important?
most important, sir, diabetes.
No, it's hypertension, smoking, diabetes, hypercholesterolemia. Okay,
Yes, sir.
right. Okay, so this patient has nothing. Have you taken the history for all this?
Yes, sir. He's not a known case of diabetes. There's no history of any hypertension, and patient is a chronic smoker.
Next slide. Why past surgical intervention? What kind of, suppose he underwent appendectomy? No, it's just past surgical intervention. What kind of
Sir,
intervention are you looking for?
I'm
Tonsillectomy. Suppose he had undergone tonsillectomy.
yes, sir.
Then
Sir, in
No, then
this
yes, so what?
particular, yes, sir, I'm looking for intervention related, like whether in terms of any cardiac or limb disease. For example, in case of any cardiac disease, has the patient undergone any previous history of bypass surgery or any graft surgery? Or in case of limb
So
disease,
be
has he
more
undergone?
specific. Palak. Be more specific,
Yes, sir.
right? You just can't say fast surgical intervention. And let me figure out what do you mean by it. Okay, next slide.
Okay, sir.
Okay, smoking. How does smoking cause? Why is smoking so bad?
Sir, smoking is the chemical responsible will be nicotine, so it will contain it will affect a lot of processes in the body. Firstly, the inflammatory process of the body will be affected. There will be uh,
So
high source of
atheroma is a disease of the intima, the media, or the medium.
sir,
Where
atherosclerosis will
does that
mainly, sir, intima and the media mainly.
it is usually below the intima, right? They keep growing, and then the intima breaks down, and then they can break off and form emboli, or they can close the vessel.
Plaques.
Okay.
Yes, sir.
So yeah, so this causes inflammation and makes the wall sticky, so that you have platelets sticking around there. They cause inflammation. They break down the intima and move inside. And then the cholesterol and calcium deposit, all that kind of stuff. Okay, next slide. What is his age? 54. His age is 54. So what is accelerated atherosclerosis? Accelerated atherosclerosis. Have you heard of it?
Accelerated atherosclerosis. Sir, in patients with other comorbidities, like for example diabetes, the stigmata of atherosclerosis will be present a decade earlier. Mm, A decade, they might present a decade earlier. In that
Stigmata. Why
cases,
do you say stigma? Right. The effect, a person who develops atherosclerosis much earlier than what is expected.
yes,
Right.
sir.
So, okay. Next slide.
Sir,
So what's
I'll
the
be.
differential? Now, what's the differential? So what's the differential for this? He's got pain and he's got gangrene of the toe.
Sir, in differential diagnosis, uh, one I would like to keep a case of thromboangiitis obliterans, which will have its own positive and negative factors. And
Okay. Why do you think it can be or can't be thromboangiitis obliterans?
sir, it can be thromboangiitis obliterans because, first of all, there is no other risk factor in this patient as of now other than smoking, which is a supporting factor in evidence of thromboangiitis obliterans. Second of all, I would say that the patient has presented with gangrenous changes involving the most distal extremity.
Palak. There's a
Yes, sir.
what is the criteria? What is the criteria called? Shinoya's criteria.
Shiono criteria, sir.
Okay, so that's for TAO. So
Yes, sir.
what does Shinoya say?
It says that the patient should be age. The age of the patient should be less than 50 years.
Very good.
The patient should have a smoking history without presence of any other risk factors.
Very
And
good.
there should be involvement in the upper limb in the form of either or the veins, phlebitis, and
Don't come again, please. There can be superficial thrombophlebitis.
thrombophlebitis or upper limb involvement in a patient with
Okay.
thromboangiitis obliterans, and
Right.
recent history of smoking and no other risk factors, and all other that is it, sir. And
Only
the all
peripheral
other
limbs and not multiple organs. affects only peripheral limbs and not multiple organs, right?
Yes, sir.
Hello.
One more
And
criteria.
and the pain is much more in thromboangiitis obliterans. Why? Why is it much more?
Because, sir, it is a inflammatory. First of all, it is an inflammatory pain which will be involving uh, segmental disease would be there and multiple because
It
of the
involves the
inflammatory
neurovascular
nature.
bundle right in the beginning. It involves the neurovascular bundle right from the beginning.
What
So
is
the nerves are
pathology?
involved right in the beginning. You get me?
Yes, sir.
What is pathology
While
of
in
Berger disease?
atherosclerosis, the nerve
What is the
Pathology of Berger disease.
methodology, sir?
Pathology.
Sir, in
Pathogenesis of
Burgess
Berger disease.
disease,
Hmm.
sir, it is basically a type of vasculitis in which there will be inflammatory thickening of the entire vessel wall, unlike atherosclerosis, which will only affect the intima. This
That
Burgess
indicates
will affect all three layers of the vessel wall.
it is a panarteritis.
Yes,
It
sir.
is a
It is a panarteritis
panarteritis.
and which is classically segmental, and there will be no evidence of any atherosclerotic uh, plaques or disease in the vessels.
and of course small vessels are involved, right? Medium to small
Small and
vessels.
medium-sized vessels are usually involved.
Yes, sir.
Okay, should we move to the examinations? We don't have much time.
One more point I want to add. Palak,
Yes, sir.
in that criteria, absence of diabetes or hyperlipidemia, that is also one of the points in the criteria.
Just
Okay.
check that.
Yes, sir.
What is
Just
monkey
smoking and no other risk factor.
We had discussed about atherosclerosis and we discussed about Burgess disease. What is Monkey-Burke sclerosis?
What is?
Monkey-Burke.
Monkey-Burke. So not
Sir,
able to hear?
no.
Monkey-Burke sclerosis.
Vaughan gives.
Yum.
M-O-N, monkey. M-O-N, monkey. Not heard of
Monkeys
it.
Sir, I don't have any. I don't know, sir. This.
There the sclerosis occurs only in the media. It will never involve the intima, especially in a diabetes mellitus, early sclerosis, which takes mainly in the media you are getting. So it is a
Yes, sir.
panarteritis you are going to get in a Burgess disease, but here the intima will be spared and only the media will be involved.
It is called medial calcific sclerosis.
Medial calcific sclerosis.
Yeah, this calcium deposit in the media of the vessel. Okay, let's go to the examination, please.
Yes, sir. On examination, general physical examination, the patient was conscious, oriented to time, place, and person, moderately built, well nourished, inadequate hydration with a BMI of 23.2 kg per meter square. The vitals of the patient, temperature, the patient was afebrile to touch. Pulse rate was 96 per minute in the right radial artery, which was regular, good volume, no specific character. The vessel wall was not thickened and there was no radial or radiofemoral delay. The blood pressure was 136 by 72 mm of Hg in supine position in the right arm, 134 by 72 in the left arm, 130 by 76 in the right leg, and 126 by 70 in the left thigh. The respiratory rate was 18 per minute and the SpO2 was 98% on room air. No pallor, icterus, xanthelasma, xanthoma, cyanosis, clubbing, edema, or generalized lymphadenopathy. The back and spine examination were normal. Coming to local examination, on inspection, the position of the patient was supine followed by standing. It was done in a supine followed by standing position. There were no apparent gait abnormalities. On further inspection of the left lower limb, the skin over the dorsum of the foot appears shiny with mild erythema, which was extending up to the mid dorsum. There was no obvious loss of hair or muscle wasting in the calf muscles. There was blackish discoloration of the great toe with slough present over the tip and the lateral aspect. There were brittle and deformed nails of all the toes. There was no visible demarcation line and there was no ulceration or discharge. Continuing with inspection, there was mild edema present over the dorsum, no visible groin swellings, other scar marks, or visible joint deformities. On performing Burgess test, there was no obvious pallor with limb elevation and no evidence of any dilated tortuous veins. On comparison with the right lower limb, the brittle nails were present all over the toes in the right lower limb as well, and the rest of the examination in the right lower limb was unremarkable. This is the clinical picture showing the same. On palpation of the left lower limb, the inspectory findings were confirmed. The limb was warm up till the foot region. Thereafter, it is cold till the knee joint as compared to the opposite limb. The limb was non-tender and there was no tenderness present along the veins. The left great toe showed gangrenous changes mainly in the tip and the lateral aspect. The capillary refilling time was delayed in the other toes. There was no pitting edema or crepitus. The pulse distribution is as shown. In the left lower limb, there was absence of the dorsalis pedis, ATA, the anterior tibial, the posterior tibial, and the popliteal arteries, which were present in the right lower limb. Common femoral was palpable in both the right and the left lower limb. Upper limb peripheral arteries were normal in both the arteries and palpated equally. On girth or circumference comparison, there was not much difference at mid-thigh and mid-calf level. The distribution is as shown, 47 centimeter in the right mid-calf, 32 in the right mid-thigh, and in the left one, 46 centimeter at mid-thigh and 31 centimeter at left mid-calf. ABPI was not commented because of absent ATA and PTA at the left ankle. Pulsations over bilateral carotid and superficial temporal arteries were normal. There was no palpable inguinal lymphadenopathy. On sensory examination, the loss of sensations were present: pain, temperature, touch, and vibration over the great toe, with significantly reduced sensations in other toes as compared to the opposite limb. On motor examination, there was no loss of toe movement, and other joint movements were also normal, and reflexes were intact. The right lower limb examination was unremarkable. Auscultation, there was no audible bruit over bilateral lower limb vessels. Coming to systemic examination, cardiovascular system, there was normal S1, S2 audible with no murmurs, no focal neurological deficit in central nervous system, respiratory system, bilateral vesicular breath sounds, and no added sounds. Per abdomen also, there was no significant finding. The abdomen was flat, umbilicus central, no scar marks. It was non-tender, no palpable lump or organomegaly. All hernia sites were free, no free fluid on percussion, and bowel sounds were present. Summary: a 54-year-old gentleman, chronic smoker, presented with intermittent claudication in the left calf on walking for the past 1 year, gradually progressing to rest pain for the past 1 month, associated with gangrene, which is probably wet, of the left great toe since 20 days, with absent lower limb pulses and associated with trophic changes and sensory loss as described.
So, okay, good. I think you've done a very good job with the examination. You did the Burgess test, right?
Yes, sir.
Was there any pain? You didn't comment about the pain, you just commented about the color. You didn't comment about the pain. Was there any pain on raising the limb?
No, sir, there was no pain on raising the lower limb.
Right. So I think that is important,
Yes, sir.
because I believe. Was there any smell? You said there's gangrene. Is there gangrene, dry gangrene?
No, sir,
Was the
there
line
was.
Was the line of demarcation clear? Was there any
No,
smell?
sir, there was no clear line of demarcation present. Moreover, there was mild erythema and redness over the dorsum till the mid dorsum. It is, I don't know how much
No,
it is
Palak,
visible.
What does
Palak,
it
Palak, Palak,
signify?
Palak. You have to come out with an examination when you're examining a gangrenous toe or a limb, whether it is dry gangrene or wet gangrene. So you have to mention that if there is any smell, you have to mention about the line of demarcation, if it is oozing, if it is shriveled, right? All this is
Sir,
missing there.
no, sir, demarcation line, ulceration,
Okay,
discharge, I
line
mentioned.
of
Smell,
demarcation
sir,
you said. Smell you've not said,
smell, sir, I'll take care of. Yes, sir, smell I did not mention. Smell, I will
right?
take care to put it, sir.
Right.
Palak, but you
And
have mentioned that there is no line of demarcation.
Yes, sir, there was no line of demarcation, sir.
What does it signify?
Sir, it means that still there is no visible separation between the viable and the non-viable tissues at present.
What is dry gangrene? What is difference between dry gangrene and wet gangrene? What is difference
Sir,
between dry gangrene and wet gangrene?
Sir, in wet gangrene, there will be associated superadded infection, which will be, and there may be clinical signs of, there may be putrefaction present and clinical signs of
So
swelling
line of
and,
demarcation is seen in dry gangrene or wet gangrene?
sir, it is seen in both, sir. In dry gangrene, it is formed earlier, and in wet gangrene, it may take a longer time to form until all the because of spreading infection in the vicinity of the soft tissues from the gangrenous area.
Any other significant factor that sir have already mentioned? What about the odor or smell?
Yes, sir. Yes, sir. Odor must be commented, sir. It is a feature of wet gangrene, sir.
What is the appearance
okay,
of dry gangrene? What is the appearance of wet gangrene?
Sir, in dry gangrene, the concerned part will be dry and shriveled with a it is classically described as a mummified appearance. And in case of wet gangrene, will be swelling, oozing, discharge present from the toe with putrefaction, bad smelling, foul smelling tissues from the concerned gangrenous part.
okay,
What
Palak,
about the
another
free
thing which
gangrene? What
you
is the
missed
meaning of
is, sorry, if you missed is skip lesions. You must
Yes,
mention
sir.
about skip lesions, right?
Odor. Yes, sir. Yes,
Also,
sir.
also, you've
Yes, sir.
examined both, you should examine both the limb at the same time. You're not told me anything about the condition of the integumentary system of the right limb.
Sir, in right limb, there were
You've
brittle
measured
nails
the
present.
girth, you have measured the girth, measured the girth, but visual, is the limb visually, is there a visual difference between the two limbs girth? Is there a visual difference between the color of the two limbs? Is there a visual difference between the integumentary system of the two limbs?
Yeah, apart from nails, sir, there was no other difference.
No,
The
so you have
hair
to
was,
mention it. Palak, you have to mention it,
yes, sir. Yes,
right?
sir.
You have to mention it.
Separately mentioned.
Yes,
Okay,
you
sir.
should say
Yes.
that. Initially, you start off with examining. God has given two limbs, 2 ears, 2 eyes. So you got to compare the two right at the beginning. Right?
Yes, sir.
So please. Okay. Mm, what's the diagnosis now?
Sir, my final diagnosis will be peripheral arterial occlusive disease with wet gangrene of the left grade 2 with sensory and
Why
trophic
wet gangrene?
changes.
Why are you saying wet gangrene?
Why wet gangrene?
Sir, the point in favor is there is associated superficial erythema and mild swelling, which is extending up to the mid dorsum region, and
So
there
look,
was
the
all
hallmark,
slough present in the.
Palak, the
Sir,
hallmark of wet gangrene is infection. Right? The hallmark
yes,
of
sir.
wet gangrene is infection. With
Yes, sir.
infection, there'll be odor. This is a developing, it is an evolving gangrene. The arteries
Yeah.
are closing down slowly. So you're not, there's still some viable tissue in between. the dead necrotic tissue. Isn't it?
Yes, sir.
Palak,
Yes, sir.
what is meaning of pre-gangrene?
Sir, pregangrenous
Pre-gangrene.
changes, yes, sir, they are used to describe when condition of the limb when the gangrene and ulcer have not yet settled in, but there are changes like, for example, the limb is cold, there will be pallor visible pallor present.
Patient present with a rest pain, color changes, edema, hyperesthesia with or without ischemic ulceration. It is a pre-gangrene.
Or yes, sir, or gangrenous changes.
There are 4 things in pre-gangrene, right? Color, edema,
Yes, sir.
hyperesthesia, and rest pain. 4 things.
Yes, sir. Rest pain, skin changes,
Rest
and
pain, edema,
hyper.
hyperesthesia, and color change.
Yes, sir.
Okay. Okay. So what's the diagnosis now?
Sir, peripheral arterial occlusive disease with gangrene of the left great toe, which is
Just keep it like that.
associated with.
Don't try to look, Palak. In examination, the more you say some things, you'll be interested. Just say it's gangrene. Let the examiner ask you whether it's dry or wet. Don't comment on it right in the beginning. You just say the patient has peripheral arterial disease involving the right lower limb, right? With gangrene of the right
Yes,
great toe
left great toe. Yes, sir.
or left great toe, right? That's it.
Yes.
Let the examiner ask you something. You said wet gangrene because then you fall in trouble, right? Okay.
Yes.
So now how will you proceed?
So first I would like to confirm my diagnosis. For confirmation of my diagnosis, I would like to get a ultrasound scan of the left lower limb, which Doppler scan of the left lower limb, in which case it will show the presence or absence of peripheral arterial occlusive disease in
Okay. So
combination
you
with
get just
the. Sir?
you get a Doppler or anything else?
So a duplex can be in combination with a B mode ultrasound.
Okay, so you have one B mode and you have one Doppler, right? So what does the B mode
Yes,
tell
sir.
you?
So B mode will tell me the more about the anatomy of the vessel, whether first of all, whether there is any occlusion or not. If occlusion is present.
Occlusion would be told by B mode. What sort of occlusion?
Sir, segmental occlusion or at what level the occlusion may be present in.
Acceptable. Okay, acceptable. Okay, stenosis or any plaques. Well, okay. What else?
And sir, the characteristic of the flow, whether it is.
No, look. B mode tells you you just compartmentalize outside the arch vessel, within the wall, within the lumen. Okay. So outside the wall, what will the B mode tell you?
Presence
If
of
there is any tumor there, any hematoma there, any calcified foreign body there, anything else, right? Within the
Yes,
wall, it will tell you whether there is any stenosis, any aneurysm, any plaque, right?
Yes, sir.
And within the lumen, it will tell you again if there is any plaque or anything, right? Now, what does Doppler tell you?
Doppler will tell us about the flow in the vessel, whether first of all whether there is any flow or not in that vessel.
Very good.
Secondly, what is the character of that flow, whether how phasic it is, what are the whether it is monophasic, biphasic, or triphasic, what is the flow velocity. In that also we can know from the ultrasound mode, and any
So Flow direction. Which direction is the flow going? Right? And flow pattern, whether it's lambda or
Yes, sir.
turbulent. So these are the
Yes,
things.
sir.
Very good. So what's the normal flow in a peripheral artery? Should I say posterior tibial or a femoral artery? What's the rate of flow in a normal artery?
The rate of flow. Sir,
How fast does the blood flow normally?
sir, I have seen normal ultrasound Doppler. From that, if I were to think, it is like more than 100, 120 meters per second I have seen on normal
Meters per
triphasic
second.
flow.
No, they write it below, na? It's generally 50 to 60 centimeters per second.
Okay.
50 to 60.
Yes, sir, centimeters per second.
And suppose it's 75 centimeters per second. What will you think of?
Suppose it is 75 centimeters per second.
Yeah.
Sir, the flow is blood is flowing with a higher speed. There might be any obstruction or stenosis before proximal to
Right,
that.
very good. So if the stenosis is less than 50% of the cross section of the artery, the flow will be high. If the stenosis is more than 50%, then the flow comes down.
Yes.
Okay, right. So you've done a Doppler. Have you got the report? Sir, please.
Palak, what is meaning of distal runoff?
So distal runoff is the flow which is present in the vessels distal to the site of obstruction, sir, distal to the site of obstruction or stenosis.
Okay, continue.
Okay. So do you have the report of the Doppler?
Sir, actually, this is a very recent patient. We have sent him for Doppler. He has not yet
Okay, you
come
don't
back
have.
with the report.
You
There
don't
was
have
an
it. Okay.
outside report.
What does the outside report say?
So there was an outside report in which there was monophasic flow in the left popliteal, anterior tibial, posterior tibial, and dorsalis pedis, with comparable triphasic flow in bilateral femoral arteries. Only that much was the information we had sent for a scan from our institute. It is still pending, sir.
Okay. Okay. So you've done the Doppler. Now what else will do? The patient is in your OPD, he's in pain, he's got gangrene.
Sir, because the patient is in pain, first I will, alongside giving a Doppler and investigation for confirmation of my diagnosis, I would also like to help with symptomatic management of the patient. In first case, I would give an antibiotic cover also, because of addressing the pain first. The pain will be taken care of by non-steroidal anti-inflammatory drugs. Along with that, I would like to
What is the pain
prescribe
ladder? Palak, what's the pain ladder?
Sir, first we'll start with it basically progresses from one class to from non-opioid to opioid medications, depending upon the severity of the pain. So first patient will receive non-steroidal anti-inflammatory drugs, and if it is not controlled, then non-opiates, and then finally opiates will be used for pain management.
Okay. Okay. So given you've elevated his pain, what else?
Sir, apart from pain, I would like to give him on antiplatelet drugs, aspirin, which I'll prescribe along with statins, ecosprin. Basically, I will atorvastatin or rosuvastatin, and symptomatic relief can also be provided by. I will tell the patient to include exercise in his daily routine, as it has been shown to.
You would ask him to exercise in a case of thrombus. or in a Burgess, in which do you ask a patient to take rest, and in which do you ask the patient to exercise? Do you
Burgess
ask the
versus
patient to exercise in ischemia because of
atherosclerosis.
atherosclerosis? No, in Burgess you ask him to exercise because you want it's multi-segmental, right? So you want the collaterals to open up. Here,
Okay.
you ask him to just go about enough so that there is no pain. If you ask him to exercise, there will be pain, right? And this pain is because of decreased flow,
Hmm.
right?
Okay,
So
sir.
in Burgess, in this you ask them to just control the activity. Okay.
Okay, sir.
What else? What else will you do as a resident?
Sir, then I will, since there is no clear line of demarcation yet, so I will take the patient for debridement of the left great toe along
What
with
about his
the,
X-ray of the foot? What about his general investigation? Palak,
yes,
resident
sir,
जैसा
for the
सोचो,
general,
get an
yes,
X-ray
sir,
done.
for the general, yes, sir, for the
हाँ,
general part of the workup, I would like to get normal blood investigations first, like CBC, the complete blood counts of the patient, renal function test, in which case I would get an idea of the renal function of the patient, which I might have to utilize further in planning any other investigation. And LFT is a part of routine investigation only. Then the PT-INR of the patient and diabetics. So diabetes workup, I will send the uh, random blood sugar and the fasting blood sugar. Even if the patient is not giving any history, but still I will like to do HbA1c and all these three investigations. Apart from that, ECG and chest X-ray, ECG to rule out any cardiac abnormalities for the patient, and I would also like to get an 2D echo done to rule out any proximal cardiac disease for this patient. And apart from that, in the general workup, that
and an X-ray of
would
the
be,
foot. And an X-ray of the foot.
yes, so to rule out any osteomyelitis, any bone infections or any bony abnormality also, I would like to get a X-ray done of the foot.
Okay. So now you've done everything. How do you decide when to operate and when not to operate?
Sir, when to operate, sir? Firstly, in this case, I would still depend upon clinically the line of demarcation, so which is still not yet formed in my patient. So, in this case, I would like to again take the patient for serial debridements until there is evidence of any clinically line of demarcation is present, and I would like to give antibiotic cover as well. uh, Multiple debridements until the wound is off of any slough or pus or any discharge. Once
Okay.
the clinical
Right. Okay, go on.
Sir, if there is a formation of a clear line of demarcation, then I would assess for it, and then ultimately take the patient for if and it also confirm that whether there is no proximal uh, limiting disease. In that case, I would take the patient for
How do you confirm that there's no
amput.
proximal limiting disease?
So, for example, now if in this case, if there was presence of any uh, fever or any wet gangrene or this,
Any
I
role
would
of
go
angio?
for,
Come on. Okay, let's cut the thing out. Any role of angio?
yes, sir. I would like to know, get a angiography done to look for the anatomy and the level of the disease, sir, till where is the disease extending more proximally, which would help me to further plan my management accordingly. Whether the
Okay,
patient goes,
okay, Palak, you're doing well. So let me ask you one more question. Have you heard of task 2 guidelines?
yes, sir.
What is it?
Uh, s- Sir, it is a consensus which will tell us where in femoropopliteal and in distal vascular disease, what between endovascular and surgical therapy, what will be more suitable
Open
for the
surgery and
patient?
endoluminal surgery. Okay.
Yes, sir. What will be more suitable? So, in which case, short segment stenosis are more suitable for endovascular procedures, whereas long segment uh, are more suitable for surgical therapy, provided the patient is also a good surgical candidate for the same.
So task A and B are for endoluminal, endovascular, and C and D are usually for open.
Open surgical procedures, sir.
Very good. Anyone else? Any role of sympathetic knee?
Sir, in only cases where we think that there is no possible role of revascularization or any open or endovascular surgical procedures, then to relieve the patient of ischemic debilitating pain, we can offer the patient lumbar sympathectomy, sir.
Okay. So I think I have done very well. I am impressed with the Palak. Well done. Dr. Kanagal? Okay.
Evening, sir.
Okay. Right. I think I'm done with that. She's done
Yes,
that.
sir.
Okay.
I think Srikumar sir also has joined. Srikumar sir, would you like to give your comments, sir? Srikumar sir?
Hello, sir.
Sir is still there, probably. Fine. Dr. Palak, do you have any doubts or any questions to clarify with the national examiners?
No, sir, no. I don't.
Thank you very much. Stay with us for the next discussion.
Yes.
I give our kind respects and regards to Professor Amit Gupta sir also. So
Yes.
we have Dr. Sumaya. Sumaya is from Alamin Medical College, president. She'll be sharing her presentation on varicose veins. Dr. Sumaya, please introduce yourself, your unit chief, head of the department, and start your presentation. Shikmar sir, are you with us, sir? But you start your presentation, Dr. Sumaya.
Yes, sir. Good evening, everyone. I am Sumaya Attar, a postgraduate in surgery from Alamin Medical College, Bijapur. My head of the department is Dr. Sajid Mudhol, sir, and my unit chief is Dr. Nishikant Gujar, sir. I'll be starting my presentation. Here we have a 67-year-old male by name Pirsa, who is a hotel waiter by occupation, and he hails from Bijapur. If complaints, the patient came with complaints of swelling on the medial side of the right lower limb since 10 years, dark pigmentation around the right ankle since 2 years. History of presenting illness. Patient was apparently all right 10 years back when he first noticed tortuous swelling over the right leg above the ankle region, which was insidious in onset, and it gradually progressed to involve the inner aspect of the leg and lower part of the thigh. It was appearing only on standing, and the swelling reduced on lying down. There is pigmentation involving the lower aspect of the right leg. Patient has dragging type of pain which increases as the day passes. Patient had history of ulcer in right lower limb. There is no history of edema of the leg, no history of fever, no history of abdominal distension, pain, and chronic constipation, no history of breathlessness and cough, no history of trauma, prolonged immobilization of the limb, no history of previous surgery for varicose veins, no history of long-term hospitalization. At present, there is no history of cramp-like pain in the opposite leg. Past history, there is history of sympathectomy done 21 years ago, history of left leg omentoplasty done 20 years ago. There is also history of fifth toe amputation of left leg 20 years ago. There is history of left groin hernia surgery 1 month back. No history of similar complaints in the past. There is also no history of diabetes mellitus, hypertension, asthma, epilepsy, and tuberculosis. Family history, no similar complaints in the family members. Personal history, the diet is mixed. He has a good appetite and normal sleep. He has regular bowel and bladder habits. Coming to his addictive history, he was a smoker, tobacco chewer, and alcohol intake was there since 30 years, but he left all these habits 20 years ago. To sum up, here is a 67-year-old male, hotel waiter by occupation, who came with complaints of multiple tortuous swelling in the right lower limb associated with pigmentation and pain that is more towards the end of the day. Patient has no history suggestive of any secondary causes or DVT.
Okay, Dr. Sumaya.
Yes.
So, but what do you think by your history you're dealing with?
Varicose veins of the right leg, sir.
Okay, what is a varicose vein?
Sir, varicose veins is a long, dilated, tortuous, superficial vein, sir.
Right, so which is visible, right?
Which is
So
visible,
you-
yes, sir. Visible.
Right. So go back to your first slide now.
Yes,
You
sir.
said there's swelling in the right lower limb. What is the swelling of the right lower limb? What do you mean by swelling? Next slide.
Sir,
Complaint-
yes, sir. Sir, when there is tortuous swelling, sir.
No, you can just say that they are visible, dilated visible veins.
Okay, sir.
Just say that. What is the swelling of the leg? That the whole limb is swollen, or there's a swelling, or there's a
Yes,
lump in the medial side, isn't it?
yes,
So
sir.
you know it's varicosities. So just say, you can just say that there's varicosities.
Okay, sir.
Right. And what do you think is this cause of this dark pigmentation around the right ankle?
Sir, due to chronic venous insufficiency, sir, there will be pigmentation around there will be capillary leakage of blood and RBCs, and hemosiderin will be
Blood and RBC are two different things.
yes, sir.
Just say RBCs can come out, right?
Yes, sir.
WBC and
RBCs.
RBCs, right? Okay.
Capillary leakage leading to RBC collection. No.
Okay. Next slide, please. So, what are the causes of varicose veins?
Sir, there is primary cause and a secondary cause, sir. In primary, there is we have veins that don't have valvulus, or when there is valvular incompetency, and in secondary causes we have any pathology of the involving the abdomen or the thoracic cavity that leads to incompetency of the wall, sir, which leads to pulling down of the blood in the lower limbs, that leads to tortuosity, sir, expanding of the veins, sir.
So can you tell me which is a congenital cause of varicose veins?
Congenital cause, sir. Sir, if the patient has any familial disease, sir, like
Right.
Klippel-Trenaunay syndrome and all.
ATS syndrome. Okay, that's one.
Yes, sir.
Okay. So what about other causes of secondary varicosities? You said any pathology in the abdomen or in the thoracic.
Yes, sir. Any pelvic tumor, sir.
Anything else?
Physiologically during pregnancy, sir. And when COPD and all, sir.
Okay. What about DVT?
Yes, sir. DVT is a local cause, sir. Yes, sir.
So
DVT
that's much
also
more
leads
commoner.
to.
That's
Sir?
much more common. That's much more commoner, isn't it?
Yes, yes, sir. DVT, yes, sir.
Okay. You said the patient has dragging type of pain, which increases as the day passes. Why do you think this is happening?
Sir, due to pulling of the blood down in the veins, there is a stretching of the vein wall that leads to this dragging type of pain.
Okay. Patient had a history of ulcer in the right lower limb.
Yes, sir.
What does that mean? History of what? When?
Sir, it was a venous ulcer was there, sir.
No, how long ago? Has it healed?
10 days ago, sir.
Dr. Sumaya,
Yes,
you
yes, sir.
mentioned history of ulcer, but you have not told us anything about it.
Yes, sir. It was there 10 days ago, sir. It was active till 10 days ago.
So it's important, isn't it?
Yes, sir.
So
It
how
has
long
healed
had he
now,
been having
sir.
this also? How long
He
has he
was,
been having this?
sir, he had it for almost 3 months, sir.
3 months. And how do you think a venous ulcer would heal in 3 months or in 10 days?
Yes, sir, if proper treatment is given, sir.
So was he taking treatment for it?
Just the elevation and also elevation and compression stockings.
And you think that
And
has helped?
regular dressing was also done, sir.
Okay. What is the difference between a venous ulcer and a varicose ulcer?
Sir, venous ulcer and varicose ulcer.
Yes.
Venous ulcer will be deep to the deep fascia, sir.
Very good.
And varicose will be superficial to deep fascia. And varicose ulcer will be seen only when there are varicose veins isolated, sir. And
Okay.
venous can be seen even in the absence of varicose vein in chronic venous hypertension.
Right. And which heals easily and which doesn't heal?
Sir, venous hypertension heals easily, sir. For varicose vein
Does it?
ulcer,
Does it? Venous hypertension will heal? What is the
sorry,
cause
sir,
of
varicose ulcer. Sorry, sir.
what is the cause of venous ambulatory venous hypertension?
Sir, incompetence of the walls
So
and perforator incompetence, sir.
what happens?
So there will be pulling of the blood towards the most dependent area, that is the lower portion of the leg.
Okay, tell me, how does the blood return from the lower limb to the heart?
Yes,
What are
sir.
the
Sir,
mechanisms?
yes, sir. We have two venous systems, sir. One is superficial and deep, and these are connected by the communicating vein system. First, the blood from the foot, it enters the dorsal venous arch, sir. Then from there, it enters the saphenous
Look, Dr.
greater.
Sumaya, I'm not asking you, Dr. Sumaya, I'm not asking you the flow. I'm
Yes, sir.
asking you the mechanism.
The mechanism, sir. Sir, yes, sir. We have three pumps, sir. One is the foot pump, one is the calf muscle pump, sir, and the other is the negative pressure of the intrathoracic pressure that
Okay, tell
leads
me
to
about the
the.
foot pump then. Okay, what is the foot pump?
Sir, when we are walking, so the blood within the veins of the foot are pressed, and the blood column moves up, sir.
Does it?
Yes.
No, it doesn't. Walking does not push us. It's the calf, right? You have what is known as a peripheral heart,
Yes,
the
sir. Sir,
soleus
that
and
is
the
the calf.
gastrocnemius, the calf
Yes, sir.
pump.
That is the calf pump, sir.
There's nothing called foot pump, right? The second is the valves, right? And
Yes, sir.
the third is what is vis a tergo? Have you heard of the term?
Sir?
Vis a tergo.
No, sir.
So you have the artery and the vein in a closed compartment. So when the
Yes, sir.
artery expands
Yes, sir.
during
Yes, sir.
presses the vein and the blood
Presses
goes
on
up.
the wall of the vein for the
Right.
forward movement of the blood, sir.
And of course, the negative intrathoracic pressure during inspiration.
Yes,
Right?
sir.
So
Yes,
these
sir.
are the mechanisms. Right.
Yes, sir.
Okay, next slide, please. No, so this ulcer, you must tell me.
Yes, sir. Yes, sir. I should elaborate the ulcer, sir.
Right. You should have. Okay, next slide, please. No history of edema of the leg. Why did you ask? How did you ask for edema of the leg?
We asked, sir, whether there was any swelling of the diffuse swelling of the leg anywhere in the past.
You think a patient with ulcer would not have, or even a heel ulcer would not have some edema when he's having lipodermatosclerosis?
He should, sir.
He should. History of fever. Why do you take history of fever?
To rule out DVT, sir.
So what are the components of DVT?
Components, sir. There will be diffuse swelling of the lower limb with fever, and there will be tenderness of that region, sir.
So pain, fever, and swelling of the lower limb. Okay.
Yes, sir.
History of abdominal distension, pain, and constipation. Okay.
Yes.
Why do you ask for pain, abdominal pain in
Sir,
varicose.
if there are any tumors and all, sir, abdominal tumors, there can
there
be
will be
any
pain, sir.
pelvic congestion syndrome and all, sir, that
Okay,
can have
okay.
present
Okay, what
with
is
abdominal
okay,
pain.
okay. What is pelvic congestion syndrome?
Sir, the veins of the pelvic veins, they go into congestion, sir,
Like
due
as in
to
nasal congestion.
pressing of the veins
So the
by any
pelvic
tumor.
veins are dilated. So where will you see the varicosities in pelvic congestion syndrome?
Upper part of the thigh, sir,
In the perineum,
perineum.
the vulva, the vagina, you'll have varicosities there.
Yes, sir.
So pain is not this thing for, right? So
Okay.
no pain.
Yes, sir.
Breathlessness and cough. Why do you ask for that?
To rule out pulmonary embolism, that could be a sequelae of the DVT, sir.
Okay. So which DVT in which portion of the limb is most likely to give rise to pulmonary embolism?
Sir, DVT in the iliac vein, sir. Internal
In the
iliac.
right in the upper veins.
Yes, sir.
So how does pulmonary embolism generally present with?
Sir, they present with breathlessness, sir, and decreased oxygen saturation.
No, what will the patient tell you?
Sir, the patient is having chest pain and he
Right.
comes with the breathlessness.
You miss pain. You just ask for cough and breathlessness to rule out the pulmonary embolism. Trauma where? Head injury?
No,
Limb
sir,
injury?
trauma to the lower limb, sir.
Okay. Prolonged immobilization of the limb. What do you mean by prolonged immobilization of the limb?
Sir, when there is any major surgery of the pelvis or the lower limb and the patient is immobilized for more than 6 weeks.
More than 6 weeks.
Yes, sir.
Have you heard of people traveling on the airplane for 8 to 10
Yes.
hours and they develop DVT?
Sorry, sir.
Have you heard of people traveling on the airplane,
Yes, sir.
sitting there for 8 hours and they develop
Yes, sir.
DVT?
Yes, sir.
Why are you saying 6 weeks immobilized?
Yes. No, sir. The meaning of prolonged immobilization, sir.
Yeah.
Following trauma.
So why do you say prolonged immobilization? It's just immobilization. Even for 8 hours. But
Yes, sir.
what is
Yes, sir.
Varicose triad? What is Varicose triad?
Yes, sir. It is
Everyone who sits on the
yes.
airplane for 8 hours doesn't get DVT.
Yes, yes, sir. There is venous stasis, sir. And I'll tell you, so one is venous stasis, then endothelial damage, sir,
Very good.
and coagulopathy, sir.
Right. So if a patient has some venous damage and has hypercoagulability, even if they are not immobilized for a long time, they can still develop DVT.
Yes, sir.
Right. So all this term of prolong this thing is not important.
Okay.
It's the Varicose triad. Okay.
Yes, sir.
No, at present there's no history of cramp-like pain in the opposite leg.
Yes, sir.
Did you ask for any swellings in the opposite leg? Any dilated veins in the opposite leg?
Yes, sir. I did ask, sir.
Where is that? It's not shown there.
Yes, sir.
So you're just asking for pain in the opposite leg. Why do you ask for pain in the opposite leg? You think
Because
he's having...
Because he has a history of PVD in the opposite leg, sir. At now, he doesn't have it, the cramp-like pain.
Where, hang on. Where have you said that in your history?
Sorry, sir.
Where
Sir,
have you
it's
said
there
that?
Sir, since it is not that relevant to my present presentation, so I have included that in the past history, sir.
Where is it in the past history? History of leg omentoplasty. Okay,
Yes, sir.
okay. Sorry, I missed this. Now, so you think this patient is what's the cause of varicosities in this patient there?
It's
Why
primary,
do you
sir.
think a sympathetic was done and a omentoplasty was done and an amputation of the toe was also done? Why do you think all this was done?
Because he had a PVD of the left leg, sir. Now the presentation is of the right leg, sir. Varicose veins is in the right leg.
So you think peripheral vascular disease is an isolated disease? If it's happened in the left leg, it will not happen in the right leg.
But he did not have any symptoms right back then in the right leg, sir.
So did you ask for claudication, history of claudication, rest pain?
Yes, sir. At present, he doesn't have it, sir.
Did he have it before?
It was like history of 20 years back, sir.
He had it in the both the limbs or just one limb?
Both, sir.
Both, sir. So you think it's disappeared? You think peripheral vascular disease disappears?
No, sir.
Then, so why do you think he's having? What's the cause of? Why did you say it's primary varicose veins then?
Because there are no other secondary causes, sir.
Why he has the peripheral vascular disease? There can be thrombus extending into the veins also.
Possibilities. Sir.
Right. Next slide, please. Okay. So he left all this 20 years back because he had developed all that problem on
Yes.
the left leg.
Yes, sir.
Okay. After how many years of leaving or smoking does the body come back to normal? Suppose we ask the person to stop smoking now.
Yes, sir. Yes,
After
sir.
how much time do the effects of smoking go away reasonably?
Approximately 1 year, sir.
No, about 10 years. Right? About 10 years.
Yes, sir.
Right. Okay. Next slide, please. Okay. Let's go to the examination.
Yes, sir.
So anyone else to ask the history? Okay. Let's go to the examination.
Yes, sir. General physical examination. The patient is conscious, cooperative, moderately built and nourished. He has a BMI of 23.8 kg per meter square. At the time of the examination, the vitals were BP was 110 by 80 mm of Hg. Pulse rate was 88 beats per minute. Respiratory rate was 18 cycles per minute. Temperature was febrile. He had no pallor, icterus, clubbing cyanosis. Local examination. After obtaining the consent from the patient, he was examined in a well-lit condition with exposed below umbilicus. On inspection of the right lower limb, attitude of the limb was normal with no deformity seen. There is dilated, tortuous, non-pulsatile vessel extending in front of the medial malleolus along the medial aspect of the leg and mid-thigh. There is brownish discoloration of the skin around the medial and lateral aspect of the ankle. There is atrophy blanching seen on the right lateral malleolus. Skin is not stretched or shiny, or no eczema or loss of hair. No edema seen in lower aspect of leg. There is no ankle flare. Saphena varix is not present. No deformity of the foot is seen. The left lower limb appears to be normal. On palpation, no local rise of temperature over the dilated veins, no tenderness or thickening of the veins. Lipodermatosclerosis is present on the medial aspect of the ankle region. Arterial pulsations, that is femoral, popliteal, posterior tibial, dorsalis pedis, are all felt. In Brody Trendelenburg test, it is double positive. Tourniquet test, incompetence of above knee and below knee perforators is seen. On Perthes test, the Perthes test is negative. Modified Perthes test, on doing the modified Perthes test, the varicosities shrink. Schwartz test, impulse is felt at the saphenous opening. On Prask test, blowout seen at above knee and below knee. Egan's test, depression felt at above and below knee perforator site. Morrissey's cough impulse test is present at saphenofemoral junction. On percussion, Schwartz test is positive. Auscultation, there are no murmurs heard. There is no change in limb length. Regional lymph node examination is normal. Examination of the other limb, there is loss of hair seen, shiny skin, amputated fifth toe. All peripheral pulses are normal. Systemic examination, cardiovascular system, S1, S2 heard, no murmurs. A respiratory system, normal vesicular breath sounds heard. Central venous system, the patient is conscious and oriented. Per abdomen, no swelling or mass noted. There is a surgical scar, that is paramedian scar and left inguinal scar. The bowel sounds are present. On per rectal examination, there is no evidence of hemorrhoids. Provisional diagnosis, there is varicose veins in the right lower limb of primary etiology involving great saphenous vein with saphenofemoral incompetence and above knee and below knee leg perforators without any complications with left leg TO and amputate fifth toe. The CEAP classification is C5, EP, ASP, and PR.
Okay, Dr. Sven, good work. Okay. Yeah, no, just say at your
Yes.
provisional diagnosis. You said varicose veins in the right lower limb of primary etiology. What's the difference between primary and secondary varicosities?
Sir, in primary etiology, varicose veins, sir, there will be damage to the valvular incompetence will be there, sir. In secondary varicose veins, there will be secondary causes.
So there'll be no damage to the varicose vein, to the valves.
Sir, there will be a damage, sir. But in primary, there will be like
what else? What are other differences?
other things, sir. Sir, primary, they present at a very young age, sir.
And what's this fellow's age?
He's 67, sir.
So you think it's primary then?
Sir?
You think it's primary then?
No, sir.
Okay, what else? What else?
Sometimes the primary can be isolated, sir. And secondaries will be generalized from the ankle up till the thigh, sir.
No, in primary, do they get ulcers?
In primary, they do not get the ulcers.
So do they get lipodermatosclerosis? It's got ulcers.
The complication is less, sir, in primary.
So you think this is a primary case?
It might be secondary, sir.
No, then you can say that you can put a question mark. Say I'm not sure it's primary or something.
Yes,
Definitely,
sir,
it's not primary. It's not
Yes,
primary. If
okay,
a person is having peripheral vascular disease
yes,
and
sir.
is labeling this as primary, no, I will not
Yes.
accept it. Okay.
Yes,
Okay.
yes, sir.
Let's go to your first slide of your examination.
Yes, sir.
In diagnosis, you said there is a POVD. What's the significance of it?
Sorry, sir.
What's the significance?
Significance of? I didn't get your question, sir.
You said there is peripheral occlusive vascular disease.
Yes, sir.
Arterial disease. What
Yes,
is
sir.
significance of it? Yeah. What's the importance of it?
Sir, as sir said, sir, it can be a cause for, it might be a secondary varicose veins, varicosities, secondary to PVD, sir, any thrombus that has been extended to the veins.
From artery to vein. You mean a paradoxic embolus? How can I thrombus the artery can reach veins? Okay, you have any arterial disease which has a venous component also? Any arterial disease?
Yes, sir. I got the question, sir.
Yeah, which has a venous component also?
AV malformation, sir.
AV malformation. Okay. Any other disease? Peripheral arterial disease, at the more specific.
Yes, sir. Peripheral. No, sir. I have no idea.
Any disease called a thrombophlebitis, arteritis, venous which affect the small arterioles seen in BD smokers.
No, sir.
From TAO, thromboangiitis obliterans.
Yes, sir.
Yes, it is an arterial component and it has a venous component.
Yes, sir.
But that's not the answer of my question. In
Yes,
a
sir.
varicose vein patient, yeah, there is POVD. The significance are, one thing is any varicose vein patient needs a compression management. Okay.
Yes, sir. Yes, sir.
Yeah, if you have a POVD, if you apply compression management, that can affect the arterial flow also.
Yes, sir.
So we should be, yeah, in a case of patient, a varicose vein patient with a POVD, you have to be
Yes.
careful when you have compression bandage. You should
Yes,
make
sir.
sure that distal flow is, distal limb is, it will not
With
go for a
arterial
gangrene.
flows. Yes, sir.
Yeah, yeah. Second thing is, if you plan, if there's a thrombotic disease, you can think about a bypass in future. For the arterial disease, saphenous vein is required.
Yes, sir.
So in these cases, if you have to treat the varicose vein, you have to think about a saphenous vein sparing procedures.
Yes, sir. So that can be
Okay.
utilized for the bypass.
Yeah, bypass.
Yes, sir.
Yes, sir.
Yeah, right. Okay, let's. Okay, next slide, please. Okay, you said attitude with no deformity seen. What deformity are you looking for?
Sir, equinus deformity, sir.
Why does that happen?
How it occur?
Sir, when there is after chronic venous insufficiency, there is development of the venous ulcer, sir. To get rid of the pain, the patient starts walking on his toes, and when he continues to do so, there will be shortening of the tendon, Achilles tendon, sir. That leads
So
to this.
why does walking on the toe lead to alleviation of pain?
Sir, there will be straightening of the veins, sir.
No, it stretches the fascia. It's a kind of a compressive stocking. When you do
Yes,
like
sir,
that, you feel
yes,
the
sir.
muscles contract, don't you?
Yes, they
So try to
yes, there
keep
is
the veins empty.
empty. Yes, sir. So there will be decreased pain.
Right.
Yes.
So there's dilated tortuous non-pulsatile vessel from in front of the medial malleus along the medial. Why does it happen on the medial side of the thigh, of the leg? Why does
Because
varicose vein?
there is the presence of great saphenous vein there, sir.
Right. And then there is blackish discoloration of skin over the medial and lateral aspect of the.
Sir,
Why is that?
I'm sorry, sir. It's not blackish, sir. It's brownish discoloration of the hemosiderin
Okay,
depositions.
okay, doesn't matter. Blackish, brownish, reddish, doesn't matter. Why
Yes,
does
sir.
it happen on the medial aspect of the ankle? Usually,
Because more of the veins are there towards the medial side of the ankle, sir.
is it?
Because great saphenous vein originates there, sir. I mean,
Right.
it
Okay, that's
passes there.
the whole column of blood vessel of the blood volume is because the veins, the valves are not there. It is on the medial side, isn't
Yes,
it?
sir.
Why does
Yes,
this
sir.
patient have it on the lateral aspect of the ankle too?
Sorry, sir.
You said the great saphenous is on the medial side, so the
Yes, sir.
discoloration should happen on the medial side only. Why is the patient having
Yes,
it
sir.
on the lateral aspect also?
So there we have the course of short saphenous veins, sir.
So the short could be also involved. Okay, what is
Involved.
atrophy
Yes, sir.
blanche? What is atrophy blanche?
Sir, it is the whitish blanch that we see after the venous ulcer has healed.
Okay, no. Has healed. What is the significance of atrophy blanche? It is not blanching, it's blanche. CHE accent.
NCHE. Yes, sir.
Blanche. So what is the significance of atrophy blanche?
Sir, we cannot find any veins there, sir, at that particular area, and
So there's no blood supply to that area. It signifies that the skin from this area is going to break down.
breakdown. Yes,
Atrophy
sir.
blanche predicts that
There
this
is
area,
few.
there's
Yes,
no blood supply here, and the skin is going to break down in future.
yes,
That is atrophy blanche, not healing. Healing के बाद तो scar रहता है.
scar.
The scar
Yes, sir.
could be a depigmented scar. It could be a hyperpigmented scar. That's not
Yes,
atrophy
sir.
blanche.
Okay, sir.
Next slide. It's not stretched. What do we mean not stretched?
Sir, when there is edema of the foot, sir, edema of the leg, so the skin gets
Hang on.
stretched.
We've been talking about edema of the. What kind of edema is usually seen in patients with varicose veins?
Pitting, sir.
Okay, and
How will you differentiate the lymphedema and varicose edema?
yes,
Sir, in lymphedema, there will be no pitting, sir.
what is Stemmer's sign? Okay, let's come to that. What is Stemmer's sign? Have you heard of Stemmer's sign?
No, sir.
This is to distinguish between pitting and non-pitting edema. So tell us why does pitting happen or pitting does not happen? What's the cause of pitting?
Sir, in case of varicose veins, sir, there will be extravasation of the fluid and capillaries out of the vascular area to involve the area, sir, extravascular area. So when you press, the fluid gets displaced and you see pitting there, sir.
Right. Non-pitting edema?
Non-pitting edema, there the lymph is very thick, sir. So it does not allow for indentation.
So there is a lot of fibrosis because of chronic inflammation, right? So you
Yes,
can't press on it. Press on it,
yes,
doesn't disappear.
yes,
And usually non-pitting edema happens on this what is hump, dorsal hump, right?
yes, sir.
While pitting edema happens usually on the sides.
Yes, sir.
On the so early morning pitting edema is usually present in primary varicose veins.
Yes, sir.
But it is absent in secondary varicose veins.
Okay, sir.
No edema seen in lower aspect of the leg.
Yes, sir.
Okay. What is ankle flare?
Yes, sir.
Ankle flare.
Sir, what is ankle flare, sir?
So, Dr. Srikumar, you're muted.
What is loss of hair significance here?
Sir, much of the PVD changes we did not see in the right leg, sir. It is a sign of chronic ischemia, sir.
Okay, so you're thinking about arterial also. Okay.
Yes.
What about eczema? Why do you ask for eczema here?
Sir, it is one of the complications of the varicose veins, sir. Due to hemosiderin deposition, there will be
It's called eczema.
itching. Sir?
It's called eczema. It is called eczema.
Dermatitis, sir.
Yeah, it's like
What's
a
the difference
dermatitis.
in eczema?
Sorry, sir.
What's the difference? What's the difference in eczema and dermatitis?
Dermatitis involves the superficial layer of the skin, sir.
And eczema involves the whole of the skin. Eczema is an allergic form, isn't it?
Allergy. Yes, sir.
Allergic form. Dermatitis can
Dermatitis
happen
can
because
be
of anything. Can
any
be
allergy.
infection, allergy, anything, right?
Yes, sir.
Okay. Staphna varix. What is Staphna varix?
Sir, it is the bulge seen at the end of the great saphenous vein when it opens into the femoral vein, sir.
Okay. What is that opening called?
Saphenous opening, sir.
Okay. What is that? It's called? Okay,
Saphena
saphenous
varix.
opening. Yeah, it's a defect in which layer of the lip?
Sorry, sir. Defect in?
This opening is a
Fascia
defect
lata,
in
sir.
So how will you, suppose there was Staphylococcus varix, how will you know
Yes.
there is Staphylococcus varix?
Sir, for that we have few tests, sir. First is on inspection. We ask the patient to stand and we ask the patient to cough, sir. We can see a visible cough impulse. Then on
Okay, very good.
palpation, sir,
Hang on,
we
hang
have
on, Sumaya. Hang on,
Yes,
Sumaya.
yes, sir.
How will you, this is not a femoral hernia then?
I'm sorry, sir.
How will you know this is not a femoral hernia?
Femoral hernia, sir. Sir, it is compressible, sir, Safena varix.
In femoral, we compress it.
And this is reducible, sir. Femoral
Will
hernia.
reduce it. Femoral hernia will be reducible. This is reducible.
Sir, then for confirmation, sir, then we'll have to do this palpation and auscultation, sir.
Palpation.
Safena
Where, what,
varix.
how will you confirm on palpation?
On palpation, we have the Morrison's test, sir. First,
What is
we ask
Morrison's
the.
test?
Sorry, sir.
What is Morrison's test?
Yes, sir. We first ask the patient to lie down, sir. We empty all his veins and we keep a thumb of one hand. We occlude the saphenous opening. Then we ask the patient to cough, sir. When there is, then we can feel for the bulge, sir, cough impulse.
So you'll get it in femoral hernia also. You put your finger there, ask him to cough. You get a cough impulse.
Yes,
Most
sir.
importantly, sight.
Sight.
That's in the femoral. Right. Femoral hernia, the femoral canal. This is in
Yes.
in the saphenous, much lateral. This
Yes.
is lateral. That is much medial.
Yes.
Right.
Yes.
That's right.
Yes, sir.
You may get a gurgle in a femoral hernia of
Yes.
the content. You will not get it here.
Yes.
Okay. Next slide. No local rise of temperature over the dilated veins. Why did you ask for that?
Sir, when there is incompetent walls
So the
communicating
temperature
system,
rise.
sir.
So the temperature would rise on the varicose veins.
Sir, vasculitis, to rule out vasculitis and also.
Varicose
So you
vein
get-
causing vasculitis. Is it for?
Because Sumaya, look,
Yes.
I'll tell you what. When you're presenting a case, try
Yes.
to don't give excess of information.
Yes. Yes.
Because, right. Because if you give information, you should know everything about it.
Yes.
Otherwise, don't even let the examiner ask you, did you feel for temperature? Said no.
Yes.
Unnecessary
And say, why
negatives
didn't you?
will give you negative. Yeah.
Right.
These
Yes.
are unnecessary negative. Unnecessary
Yes.
negatives give you negative answers, negative marks.
Yes, sir.
Okay. In what all conditions you get more temperature in varicose veins?
Sir, when there is cellulitis, sir.
Yeah. Then when there is thrombophlebitis.
Thrombophlebitis, yes.
Yeah, phlebothrombosis. When
Yes.
there is when there is thrombus formation.
Yes,
These are
sir.
conditions. Regular varicose vein, there was no need of a increased temperature. As such a explanation is that point is unwanted here. Okay.
Yes. Yes, sir.
Okay. Lipodermatosclerosis. What was the
Yes.
shape of the leg?
Sir, in inverted champagne bottle appearance, sir.
Did he have that?
No, sir. It occurs in the late stages of lipodermatosclerosis, sir. His was not that much of induration, sir.
Okay. So why does it happen? What's the cause of lipodermatosclerosis?
Sir, that is the lipodermatosclerosis is the inflammation of the subcutaneous fat, sir.
Inflammation of the subcutaneous fat.
Yes,
Okay.
sir. That leads to fibrosis and thickening, sir.
Okay. Why does that
Do
happen?
acute?
Sorry, sir.
What's the mechanism?
Mechanism,
What is
sir,
the
there
mechanism?
are, sir, we have the fibrin cuff theory. and leukocyte trapping theory, sir. In fibrin cuff theory, what happens is due to long-standing chronic venous insufficiency, there will be dilatation and extravasation of the RBCs, sir.
Is this theory still intact, or has it been done away with?
No, sir, it was believed to be true in the past, sir.
Okay, now what's the theory?
Leukocyte trapping theory, sir.
What is that?
Sir, due to
There is what is known as margination. Leukocyte
margination.
margination.
Yes, sir, leukocyte margination theory, sir. Sir, due to stasis of the blood, sir, the blood, there is margination of leukocytes to the capillary wall, and they get activated, sir. The leukocytes get activated and they release proteolytic enzymes, sir. That when healing, that leads to fibrosis.
Is that it? So how does lipodermatous happen? So because of localized inflammation, there is leaking capillaries.
Yes, sir.
And these RBCs and WBCs and all those inflammatory factors, they all come out. And
Yes,
they
sir.
cause inflammation around,
Yes, sir.
right?
Yes,
And
sir.
because of this chronic inflammation and then healing and inflammation and then healing, the things becomes fibrosed at that
Fibrosed.
area. So the ankle is thin and the leg is normal shape. So it's
Yes,
like
sir.
a peg, right?
Yes, sir.
Or an inverted champagne bottle.
Champagne.
Right. Next slide, please. Okay, what is Brody-Trendelenburg test?
Sir, it is a test to see whether this saphenofemoral junction is incompetent and whether the communicating system is incompetent, sir.
So you have
We,
Trendelenburg 2 and 3, 1 and 2, right?
yes, sir. It
So
has
you're
two
right.
parts, sir. Part
Right.
1 and
So you're
part,
right, Dr.
sir.
Sumaya.
Yes,
It
sir.
is always good. It is always good to write
Part 1 and
Trendelenburg
part.
1 for
Yes, sir.
And two.
SFA, positive or
Okay.
negative.
Okay, sir.
Trendelenburg 2 for perforators, positive or negative, and which
Yes.
perforator.
Okay, sir. Okay, sir.
What is Perthes test and what is modified Perthes test? Did
Sir.
you do both of them?
Yes,
Did you
sir.
do Perthes and modified Perthes? Okay,
Yes, sir.
what's the difference between the two?
Sir, Perthes test is a subjective test, sir. Here, the patient tells that he has pain or not. But in modified Perthes test, sir, we can see the varicosities, whether they're shrinking or they're increasing in size.
Okay,
In Perthes
but
test, sir, what we do is
no. I'll
yes.
see. Yeah, go on. Perthes, what do you do?
In Perthes test, sir, we take a elastic bandage, compression bandage, and we crepe
Very good.
bandage, sir,
Okay.
crepe bandage, and we start compressing from the ankle to the thigh, sir.
That's fine. That's fine.
And
So,
then we ask
so
the
why was
patient.
Perthes given? Why was Perthes test done away with?
Why was Perthes test done, sir?
Why was it
Done
done
away.
away? We don't do Perthes now. We just do modified Perthes.
Yes, sir. Because it is a subjective test, sir.
In
The
subjective.
patient tells you whether he has or not. You cannot see it, sir.
Right. You cannot see it. That is why, because it's covered with a bandage.
Yes, sir.
That is what was done away with. So what does Perthes test tell you?
Sir, that is depending on Perthes test, sir. We decide whether to operate the patient or not, because
What
when
does
there is a
Perthes test tell you?
DVT,
Right.
sir.
So you write Perthes
Yes, sir. To
test
see
for
for
deep vein.
DVTs in the veins, if there is DVT present, sir.
Yeah. You write
Yes.
modified Perthes test for deep vein thrombosis is negative.
Yes, sir. It's
All
negative.
the Schwartz test, Pratt's test, Humpty Dumpty
Yeah.
test, they're all done away with. You don't do them. Okay?
Yes, sir.
We don't do them.
Yes.
There are only 3 tests which are important.
Yes.
Trendelenburg 1, 2, and Perthes.
Yes, sir.
All these tests have gone into the dustbin because we've got a handle Doppler.
Yes, sir.
Right? We don't
Yes.
depend on them. Pagan's
Yes.
test and all that. Okay, next slide. Right, next slide.
Leave it. Leave it, neck close. Leave it.
Yes.
Yes, okay.
Okay. So, what was it? Now, what's your diagnosis? C what?
Sir,
C5.
sir, it is C5.
What does C5 mean?
It is healed ulcer, sir.
You said there's no ulcer.
Sir, it was
Where's
there in
the
the past, sir.
where's the ulcer?
Sir, now
Show me
it
the
is
picture.
healed, sir.
Is there a scar? Let me see
Where
the
was
scar.
that?
Let's see the pic.
Yes, sir.
Okay. Okay. Here's scar. Good. Next.
E,
E. Next.
Is yes, sir.
Okay. Next slide. Yeah. Now E. EP.
Yes,
G,
sir. ASP.
AS, okay.
E is primary. Etiology is primary.
It's changed to secondary now, sir.
Yeah. And if you're not sure, you can put a question mark.
Okay,
It's
sir.
not important. A.
A is SP, sir. That is superficial system, and the perforator system is involved.
Okay. So how many perforators are there? Okay. What are the types of perforators? First, you tell me that. What are
Sir,
the
we
types
have
of perforators?
direct and indirect perforators, sir.
Okay. What are direct perforators? What are indirect perforators?
Yes, sir. Direct perforators, there is a direct communication between the superficial system of veins and deep system of veins. In indirect perforators, sir, there will be a muscle sinusoid present before the superficial system drains into the deep system.
So if you have perforators, which
Yes, sir.
perforators do you ligate?
Direct ones, sir.
Yes, you can't ligate the indirect ones.
Yes.
Okay. Okay. Now how will you proceed?
Sir, first I would like to do duplex scan, sir, after doing the routine investigations of CBC, RPS. Then after first I'll get investigations done to confirm my diagnosis, sir.
Okay, you do it.
So,
What
Dr.
duplex
Doppler,
scan?
what are things to look for?
What duplex scan will you do?
Venous duplex, sir. Lower limb.
Yeah, so you're going to write duplex scan venous, right?
Venous, yes, sir. Venous
Right
duplex scan of the
lower limb.
right lower limb.
Would you like to do the thing of the left lower limb also?
Sir, clinically, I don't see any varicose veins there, sir.
Yes, because you've not examined the left vein. Are the pulsations normal in the left vein? Left leg.
Yes, sir.
Where have you written? You've
Wherein-
not examined.
Yes, sir.
Examined that.
All peripheral pulses are normal, sir.
Okay, I think it should be more elaborate on this. All
Yes, sir.
peripheral pulse means what? Radial pulse should be more elaborate, right?
Yes, sir.
The left limb has to be examined.
Sorry, sir.
The left limb has to be examined more thoroughly than just this.
Okay, sir.
Because in this 10 years, that thing could have progressed.
Yes, sir.
Okay. So you've done have you got the results of the reports of the Doppler?
No, sir.
You don't have them. Okay. Next. Okay. Suppose the Doppler
Yes.
says
Yes, sir.
the Doppler says that the left, the right saphenofemoral is incompetent.
Yes, sir.
How will you
With-
say it's incompetent?
Sir, there will be backflow of the venous flows, we can see, sir.
Simple black flow?
And even the
Simple
the radiologist
backflow or
asked
you,
sir.
simple backflow or any measurements?
What do you
Measurements.
What do you do to see backflow?
Sir, that is the duplex is done in the standing lying down position, sir. Then the probe is kept at the saphenofemoral junction, and the patient is asked to do valsalva maneuver, sir.
Yeah.
In that, if we see there will be color mapping done, sir. If it is
Okay.
red, it is uniphasic flow, sir. When there is blue, sir, it means there is biphasic flow. It means the
Hang on.
No,
yes,
no,
yes.
no,
What
no,
is-
no, no.
No, hang on. What is red color and what is blue color? What is a Doppler? What does Doppler mean?
Sir, it is a radiological investigation, sir. It is done for seeing the flow within the vessels.
So what is Doppler phenomena? What's the physics
Sir,
behind it?
sound waves, sir, when the reflection of the sound waves is caught and interpreted, sir.
So when a train is coming into the platform with its horns, when it's coming towards you, it becomes louder,
Yes, sir.
and then when it moves away, it becomes
Slower.
less. Right?
Yes, sir. Yes, sir.
So that is because the red color is it
Towards
towards
the
or moving
saphenofemoral
towards
junction. Yes, sir.
when it's
Towards the
moving
probe.
towards the flow, right? So
Yes,
the
sir.
waves are compressed, and when it's moving, the waves move apart.
Yes, sir.
Okay. So you've done a Doppler at the saphenofemoral. It says that saphenofemoral is incompetent, and rest
Yes.
of the perforators are competent.
Okay, sir.
So what will you do now?
Sir, I will plan for a Trendelenburg surgery, sir.
Okay.
What is
Trendelenburg.
Trendelenburg surgery? What are the parts of Trendelenburg surgery? Components.
Yes.
Yes, sir. First, sir, there is ligation of the tributaries of the great saphenous vein, sir.
How many tributaries ligate?
3, sir.
Hmm?
The rest
3,
will be,
sir.
rest will be. What about the rest?
How many tributaries are there at the opening?
3, sir.
Just 3.
Only 3?
Yes, sir.
First, आगे बढ़ो, please. Tell us more. Okay, tell us the names. Tell us the
Sir,
names.
yes, sir. Sir, superficial circumflex iliac, sir, vein. Then superficial external pudendal vein. Then superficial epigastric vein, sir.
See, there
And
are
what about the
3 named
anterolateral and
tributaries.
anteromedial, posterior-medial? What is the posterior-medial vein known as? There's a name for it.
Posterior-medial?
Vein.
Yes, sir.
You missed 2 veins, the anterolateral and the posterior-medial. The
Yes.
posterior-medial is an important vein.
Yes,
It's got
sir.
a name.
Yes, sir. Posterior-medial. Arch, sir.
No, that's arch of Leonardo. This is vein of Giacometti.
Giacometti, yes, sir.
So what is
Sir,
the
it is
importance of this vein?
Sir, it is one of the tributaries of the saphenopopliteal vein, sir.
Yeah, it's the vein connecting the great system to the short system,
Short system.
right?
Yes.
That's
Principally, if you have
they've got
to
5
ligate
veins.
all the principally, you have to ligate all the tributaries.
Yes, sir.
3 named tributaries, 2
Yes.
very important tributaries. Even
Yes.
literature says up to 11 tributaries have been described in papers. So the thing is, you have to ligate all the named and unnamed tributaries there. Okay.
Okay. Yes, sir.
Why is it important to ligate all of them? Why is it important to ligate all of them? You are going to remove the great saphenous.
Yes, sir.
हटा देंगे तो बाकी को छोड़ दो. Leave them. Why spend time looking for them and ligating them?
So stripping becomes difficult, sir, when
No, stripping तो नीचे चला गया.
recurrence, sir.
Because this leftover veins, some critters can move directly. They don't go through or they can just creep down the saphenous opening and open into the femoral, and there'll be recurrence.
Okay, sir.
Right? That's why.
Yes, sir.
So
Okay,
that's
so
one
this is
component.
one. What are the other components?
Sir, stripping of the great saphenous veins.
No. Trendelenburg is
Sorry,
not
I'm sorry,
stripping.
sir. The flush ligation of the great saphenous veins, sir.
What is flush ligation?
Sir, it is ligation of the great saphenous vein close to its opening in the femoral vein.
Fine. Okay. Then third component.
Stripping of the great saphenous vein, sir, up to the knee.
Stripping is again not the component.
Sir,
Stripping is not the component. Stripping is a different procedure.
yes, sir.
You have to remove at least 2 to 3 inches of saphenous vein, proximal saphenous vein.
Proximal
Okay.
saphenous. Yes,
Yeah.
sir.
These three are the components. Then fourth one is stripping is an optional treatment. Some people never strip, some people strip.
Okay.
Okay, why you are stripping only up to knee joint? Why not below down?
Because below the knee, sir, great saphenous vein is in close proximity to the saphenous nerve. To avoid
happens-
injury to the nerve, we avoid stripping it below the.
What happens if the nerve is injured?
There will be loss of sensation of the leg, sir.
Leg? Where leg?
Thigh and the leg, sir.
Thigh.
What's the thigh? You think saphenous vein goes, you'll go the thigh, will denote the thigh. So when you damage,
Okay, what are the
it will
Yeah.
affect the inner knee, the ankle, and the calf. Right?
हाय हाय बस यही एक कमी रह गई थी तो क्या किसी गाने वाले के घर भी आना जाना है तो इसमें कौन सी बुरी बात
Okay. Okay. So
what,
you've
what are the
done that.
steps you take? What are the
Okay.
steps you take to prevent saphenous nerve injury?
Steps
Any
we
other
take,
step you take?
in
One
Trendelenburg
is you
surgery,
stop-
sir.
Yeah, one is you stripped up to the knee joint.
Only the knee joint, yes, sir.
Then, how do you strip? From below upwards or above downwards?
From below downwards, sir.
Below downwards.
Sir, we take an incision up, sir.
Below downwards? What do you mean by below downwards?
Sir, I mean from
It can
from
be below
above
upwards,
downwards. Above downwards.
above downwards.
Yes.
Yes. Okay. Any other procedure you do? You have done a Trendelenburg operation. You have done a stripping. Any other procedure?
For same patient, sir, with this
Yeah.
only
Yeah.
isolated saphenopopliteal junction incompetence, sir. Saphenofemoral junction.
This patient, there is a perforator just above the ankle joint.
Yes,
How will
sir.
you treat it?
Ligation of the perforator, sir.
If you have you have 3 or 4 perforators, at below one is just below the knee joint, 10 cm below the knee joint, then
Yes,
another one is 20 cm below the joint, knee joint,
Yes,
another
sir.
one is 5 cm above the ankle joint.
Sir,
Have
we
any other
can give
procedure?
the yes, sir. We can give the patient an option of SEPS, sir.
What is subs?
Sir, it is subfacial endoscopic ligation of the perforators.
What is Dodd Cocket operation?
Sorry, sir.
What is Dodd Cocket operation?
Dodd and Crockett, sir. There in that multiple skin incisions are given and the perforators are taken up and ligated, sir.
Is it a multiple incision? It's a single incision for
Yes, sir.
subfacial ligation.
Yes.
You go behind the deep fascia, identify
sir.
the perforators there, you ligate it, all
Yes,
the
sir.
significant perforators. Okay. What is meant by a significant perforator? Which one?
Significant perforator, sir. I don't know, sir.
If the perforated size is more than 3 millimeter, or
Okay,
there is a reflex which lasts for more than 350 milliseconds or 3.5 seconds. Okay, these
Okay,
two,
sir.
if these two are suggestive of a significant perforator, and all the significant perforators has to be managed during the surgery, either
Okay,
by
sir.
a surface ligation, or by a sepsis, or by a simple isolation of the perforated ligation, or you can do a foam slow therapy at the site. Okay,
Yes, sir.
there are
Yes.
various options to treat it.
Yes, sir.
Okay. Yes. What is your opinion about endovenous procedures?
Yes, sir. There is two types, sir. Two modalities, sir. One is laser, and the other
There
is
are lot
radio
of,
frequency ablation, sir.
there are still more. There is a glue therapy. There is a MOCA.
Yes,
There
sir.
is foam slow therapy. Many options are
Yes.
there.
Yes, yes.
How? Yes, this patient is asking you, doctor, can you do endovenous? What are the factors which will help you to decide a surgery or endovenous?
So first of all, there should be no contraindication to surgery, sir. That is, first of all, the deep system should be patent.
If the deep system is not pet, will you go for a laser?
No, sir.
Yeah. Deep system patent is a must for most of this
Any
treatment.
surgeries. Yes.
Okay, done.
Okay. Dr. Sumaya,
Yes, sir.
there was a surgery called Linton's method. Have you heard of it?
I
Linton.
forgot. Yes, sir.
Okay, let's ask you, what is Linton's line?
Linton's.
Line. So you have this line along the medial side of the leg, right?
Middle side. Yes, sir.
Along the floor, the anatomical area of the great saphenous vein.
Yes, sir.
That line is called the Linton's line. Now
Linton's
tell me,
line.
what is the Linton's method of surgery?
Superficial ligation along the Linton's lines.
Right. So what people used to do, they used to give a long incision right from the knee down to the ankle,
Yes,
raise
sir.
the skin and the fascia, and wherever you see the perforators is to be ligated. Okay, suppose
Yes.
the saphenofemoral was intact
Yes,
and
sir.
the perforators were gone.
Yes, sir.
What would you still go in for Trendelenburg?
No, sir. We would go for other endovenous procedures, sir.
Right, so this is another one where you'll have to go in for endovenous, right?
Yes, sir. Yes, sir.
I think so. Are we done, sir?
Yeah.
Dr. Kanaval.
Okay.
Right. Well done, Dr. Sumaya. Very well done.
Thank you,
Okay, good. You
Yeah,
answered
good.
most of the questions.
Yes.
Good. Keep it up.
Thank you, sir.
Okay. I'll give you a question to look for. Tell
Yes,
me,
sir.
what is crossectomy?
Sir, what is
Crossectomy.
cross-sectomy?
Crossectomy. Cross.
Yes, yes, sir.
CROS.
Cross-sectomy. Yes, sir.
Crossectomy.
Sir, Trendelenburg procedure is known as cross-sectomy
Why? Why is it called crossectomy? Very good.
because we take an incision below the inguinal ligament, sir.
No.
Cross.
You know what's a cross? These
Yes,
people,
yes.
the
Patients.
shepherds, they carry the shaft with a sharp bend on top,
Yes,
like
sir.
that, like a hook, right?
Like a yes, sir.
So this is a
Because
cross.
the great saphenous vein opens into the femoral vein in that fashion, sir.
In that fashion. And it pierces one fascia. What is the name of the fascia?
Cribriform fascia, sir.
Peripheral fascia. And what is Fox sapheni? Saphenous Fox sapheni? FALX.
Fox sapheni. I
So
don't know, sir.
The saphenous opening has got a sharp margin and a
Okay.
less sharp. The sharp margin on the medial side
Okay, sir.
is called the fox.
Okay, sir.
And these are just anatomy questions.
Okay, sir.
Okay,
What
can
is
you
a
name some
mocha?
direct? Right.
What is mocha? Mocha therapy?
यूनिवर्सिटी में लड़के हो
Yes, sir.
Yeah.
जो कर लेना है वो
Mechanical ablation of the
It's mechanico-chemical ablation.
Okay.
Okay. Because
sir.
chemical alone will not obliterate many vessels. So they're doing it's a device as a sharp end with a motor like that will produce mechanical damage of the endophasia. And
Yes.
over to that, you apply the therapeutic chemical agent like forms or something like that. Then that causes more effective. Okay, in a rough surface. That is MOCA. What is glue therapy?
Blue therapy,
Okay.
sir.
Another one. Yeah.
Yes.
Tell me
Sorry, sir.
how do you do a sclerosant therapy?
Sclerosant, sir. Sir, first by using ultrasound, sir, we mark the pathway of the great saphenous vein and its perforator, sir. Then we take an sir foam sclerotherapy, sir.
Yeah, foam sclerotherapy.
Then we introduce when we cannulate the vein by a three-way cannula, sir. Then in one of the syringes we take
No,
the
that is
sclerosant.
preparation. That is Tessari method. I'm not
Sir?
asking you. That is
Sir.
Tessari method for preparation of the foam.
Sir.
I'm asking you, how do you do a sclerotherapy?
Sir, we inject the sclerosant, sir. First we empty the veins.
Oh.
Then
Yeah.
Then we
You have to empty
inject
the
the
veins.
then we inject the sclerosant and
You empty the veins. Sorry, Dr. Sumaya, when you empty the veins, where
yes,
we
sir.
know where to inject?
Sir, first
Where
we
to-
cannulate, sir,
How cannulate? How do you cannulate?
with the scalp vein, sir.
Okay, so you put in the scalpels or needles at the
Yes, sir.
points where you have to.
Where we have to inject the sclerosant, sir. And
And then-
later we give mechanical
Then you ask
compression
him to
from
lie
above.
down. Then you ask him to lie down and
Yes,
empty
sir.
the
Then
veins.
there will be empty the veins. Yes, sir.
Right. Then you- Okay.
What you select a liquid sclerosant or a foam sclerosant? Will you select a liquid sclerosant or a foam sclerosant?
And why? And why? Why do you?
Foam sclerosant, sir.
Why?
Why?
Because foam sclerosant, sir, since we use air and all, there will be better flushing out of the blood from within the vein. And
No, you
if
use
we
a
use
lesser amount. You use
sir?
a very little amount of sclerosant.
small amount of sclerosant is used.
Because you don't want it to go into the deep
Yes,
system,
sir.
no?
Yes, sir.
What are the contraindications of sclerotherapy?
Contraindications, sir. If the patient is allergic,
Okay. Good.
As in any surgical procedure, like if there is DVT, sir.
No, DVT. In fact, DVT cases as isolated venous disease, you can do foam sclerotherapy for a non-healing ulcer. For a biliary perfect is there, that is the cause of the ulcer. And as DVT, you keep that foam sclerotherapy is an answer to it.
Yes, sir.
What are the complicated sclerotherapy?
Sir, there can be extravasation of the sclerosant and cause bleeding,
More
sir.
dangerous complication. More dangerous complication.
Anaphylaxis, sir.
No.
Sir, it may go into the deep veins, sir.
Deep vein again. It's more serious.
Sir,
Little more serious.
I'm sorry, I'm not able to get you, sir.
Little more serious. More serious. Can go to even to your brain circulation.
Yes, sir.
It can go to pulmonary circulation.
Yes,
So
sir.
make sure that there is no right to left shunt. or there's a VSD, ASD. You should be careful.
Yes, sir.
Okay.
Yes, sir.
That case, you should be carefully giving sclerosant that may go up to brain circulation or a lung circulation causing damage.
Okay, sir.
Okay, I think we're done, sir. Right?
Yeah.
Okay, Dr. Sumaya, very well done.
Thank you, sir.
Right?
Well done. Well done.
Right? All the best. You have any questions for anyone? Any doubts?
Any reverse
sir.
questions?
Yeah.
No, sir.
Okay, thank you so much. Thank you,
Thank you.
everyone. Right, good night.
Kanagavel sir,
Yes, sir.
I'm sorry, I
Um,
was in a case, I could finish only by 9.
No problem,
So,
sir. Actually, it looked that you have joined. That's why I've been trying to reach out to you. But anyway, sir, I think Dr. Jailal was there for the first case and he had to leave. And then Dr. Ajisai was almost with 2 hours or
Batting
2.5
throughout.
hours, he was continuously helping her to do the
The
programs.
opening batsman carrying throughout. Sorry, sir.
Like this
Thank
month
you,
has
too.
been a little tough with others because many programs are happening.
Yes.
Anyway, for the coming week, we will not be having the PG clinics in link with the National ASICON. And then subsequent week, we will be having probably a soft tissue tumor session. We will keep you informed. We wish all the PGs good luck for the upcoming poster and free paper presentation. We look forward for yet another program on 22nd of December. Thank you, Sahai sir. Thank you, Shikmar sir.
Right.
See you all in
And
Vaishak.
all the dear students.
See you all in Vaishak.
Sure,
Yeah.
sir. Sure. Thank you very much, sir. Thank you.
Right. No,
In
sure.
fact,
Good night.
Good night, everyone. Good night.
Kanagavel sir, you
Yes,
should give
sir.
us a dinner for the Vaishak for all the examiners.
Yes, sir. We can,
We
sir.
should get,
We can. Sir,
we can have
I've
a small
in fact
get-together.
communicated to others. We'll definitely meet. 14th evening, will that be fine? You let me know, sir.
Yeah, I'll be there.
Where are you
Because
staying,
I'll
sir?
actually get it.
Where are you
Official
staying,
that
sir?
Dasapalla some hotel.
Oh, no problem,
Mumbai
sir.
style.
We'll meet on 14th morning. And whoever
Okay,
is
sir.
there, I will post them in one of the places, sir. Definitely.
Where are you staying?
This is Green Sea, sir. Green Sea.
Okay, sir.
All the
sir.
other members are put there.
Okay.
That
sir.
does not
Thank you.
matter, sir. I think Vizag is not a very big city. We can keep traveling to one of the places. Either all of you can come to my place or I will come to your place. That can be done, sir. I will try to host all of you, sir.
I have 3-4 assignments. Let me see. It's organize those things. Then I'll inform you, sir. The 3 days.
No problem, sir. Provisionally 14th evening. I think 15th they are giving a dinner, I guess. So, our 13th evening, whoever is there also, we can meet. I'm arriving 13th evening, sir.
Sir, 30th is presidential dinner for the GC and a faculty dinner is there.
Okay.
Okay.
Thank you, sir. Good night, sir. Good night, friends. Good night, all dear friends.
Good night, sir.
Nishikant, sir. Good night, sir.
Good night, sir. Good night. Thank you.